And so, welcome to our town hall series for CAPS, in particular the Implementation Science and Health Systems Core. We are honored and privileged to have Dr. Andrew Forsyth join us today, and he's going to let me tell you a little bit about Andrew, and then I'll tell you a little bit about what he is going to be sharing with us. So Andrew is a public health professional interested in the complex interplay between individual, social, and structural factors influencing health behavior. Until 2021, he led the CHRP's California HIV Research Program at the University of California Office of the President, spearheading efforts to fund cutting-edge science aimed at bridging gaps in HIV prevention and treatment outcomes both within California and beyond. Before that, he served as the director for the Office of Research and Science at the U.S. PEPFAR, where he focused on integrating research insights into improving global health prevention and treatment services. Yet before PEPFAR, he was a program officer at National Institute of Mental Health, managing a portfolio of HIV prevention research grants and centers, including CAPS. And he is now an independent consultant, leveraging his expertise in public health and HIV/AIDS. He holds a Ph.D. in clinical health psychology from Syracuse University and completed a postdoctoral fellowship here at UCSF. He also likes surfing, so that wasn't anywhere in here, but it should be. So the title of Andrew's talk is Mainstreaming Behavioral and Social Sciences in HIV Prevention and Treatment, Unpacking the latest PEPFAR Five-Year Strategy. So Andrew, welcome, and I look forward to hearing what you have to share with us.
Thank you so much, Mallory, for the kind introduction. And it's nice to see so many familiar faces, colleagues, friends, and others. So thanks so much for the invitation to be here. And again, I want to say thanks so much for the opportunity to join you. I'm actually really thrilled to talk with you about this topic because, in fact, this is in some ways the work that I have been dying to do for many, many years. Through my years at postdoc at UCSF, my work at NIMH, at UCOP here in Oakland, the entirety of my career has really been looking for opportunities to better integrate behavioral and social sciences into HIV prevention and treatment services. And the fact that I get to do that now in a novel way has been really empowering, exciting, et cetera. So what I'd like to do is walk you through the latest iteration of the PEPFAR strategic plan. Before I do so, I want to say a couple of things. One, all of the perspectives that you hear presented today are my own. While I've been consulting for USAID for the last year in this particular area, and working with the Office of Research and Science and the behavioral science team there, everything you hear from me today really reflects my own perspective. So please bear that in mind. But what I would offer, at least at the outset, is what I think the take-home message is for me personally, having worked in this space in different capacities, and that is with the new PEPFAR leadership, I think there is a genuine interest in harnessing behavioral and social evidence-based behavioral and social sciences to improve the global HIV response. And I think this is true in a way that I've not seen in my many years as a federal employee, at state, at NIH, et cetera. I think you can hear this from Ambassador Nkengasong, that, there's a real interest in finding ways to optimize the existing programs, prevention treatment in particular, throughout the 50 countries that are supported by PEPFAR. The challenge, in my view, and we'll get to this, is we really need to figure out how to bring the behavioral and social scientist expertise to the table, both here in the States, in country, et cetera, in ways that really can help ensure that the science has a chance of making the greatest impact. So let's walk through the new strategy. What I'll do is I'll just reorient you. For those of you who don't live and breathe the PEPFAR strategy, I'll just sort of walk through some of its track record. I'll go in depth in thinking about the strategic pillars and the behavioral and social sciences opportunities within them. If you look at the strategy, you'll see, oh, well, there's one spot in particular that highlights the role for behavioral and social science, and it doesn't really apply elsewhere. In my view, that's not true at all. As you dig into the strategy, you'll see there are a range of ways that the science that that the science that's accumulated over the years can really help to improve what's happening on the ground. I'll spend a minute talking about some key challenges, and then I'll summarize and think a little bit about future directions. But I really, really would like to have some of the time for discussion at the end, because there's a great opportunity, I think, to hear from you and for CAPS in particular, to think about the contribution that it might make to some of the challenges that I'll raise. So for those of you, again, who don't live and breathe PEPFAR, the 2022, in 2022, the new 5-year strategy was released. And the mission really is to accelerate ending the HIV pandemic as a public health threat by 2023. And it does so in a way that aligns very nicely with the Sustainable Development Goals. The specific objectives or goals for the strategy itself are, of course, to reach the global 95 targets for all genders, all ages, all population groups, key and priority populations. It's really reduced new infections dramatically through the use of prevention, effective prevention and treatment services, and in particular close persistent equity gaps that we all know about from our work, focusing on key and priority populations in particular. But there are new emphases to really transform the program in a way that allows us to have a sustained impact over time. And part of that emphasis is really on engaging host governments and in-country expertise, advocates and others, private sector partners, to really ensure that what we do has a chance of lasting over the years. And again, key to that will be ensuring that that the way that we approach these goals is really responsive to local priorities and needs. And then finally, a final goal of the new strategy is really to make measurable and sustainable gains, not just in respect to the response to HIV, but also strengthening health security in a way that helps to prepare us for future or emerging public health emergencies. This is just a very quick sort of financial, if you will. So those of you who know of PEPFAR know that it was launched under the Bush administration in 2003. That's still the single best thing that administration did, in my view. This was and is still the largest single disease response by any nation, or at least I should take that back if we take COVID into account, but before then, certainly the largest. Over 20 years or so, $110 billion were invested in the global health response. And, as recently as FY23, that came to about $6.9 billion, but divided through bilateral funding, right, between the US government and Malawi or Zimbabwe, as well as a multilateral component through the Global Fund and other partners. The FY 2024 budget is reduced slightly to $6.8 billion. And I think this is a harbinger of things to come. I'm not going to get so much into the politics of reauthorization or what's happening there, but obviously that is an area for concern. If you look closely at the strategy, this is a nice table that our Kaiser colleagues, Jen Cates and our colleagues, developed some time ago. If you look at the strategy, you'll see that many of the services and programs really try to touch upon these 4 areas: testing and prevention, treatment and care, health system strengthening, socioeconomic supports. Everything that you know about PEPFAR is largely included here. Under testing, we really are talking about facility and facility-based, community-based testing, sexual prevention programs, harm reduction efforts, and of course, VMMC. I might throw PrEP in here as well. With treatment and care, obviously, we want to make sure that we have effective antiretrovirals available for adults and children. All the wraparound supports. I think there's been real progress in terms of making TB preventive therapy available in recent years as well. Under the Birx years, there was an emphasis on being sure that we were doing cervical screening, cervical cancer screening, and treatment for women living with HIV. The health system strengthening component has always been, I think there might be somebody eager to join us in the background there. The health system strengthening has always been has been central, but in recent years, as you'll see, the focus on really building or enhancing the capabilities of the healthcare workforce are really pronounced here. You'll also see in one of the pillars that there's a new emphasis on innovative surveillance methods and deeper in the strategy is a focus on ensuring improved fiscal management of these resources. And then finally, the last column of activities are, again, very familiar to many of you. I think the one that stands out so much for me is that there's been a greater focus in recent years on assessing the laws, regulations, and other policies that we know in countries like Uganda and elsewhere are drastically threatening the progress that we've made in our response. And thankfully, there are, I think, some evidence-based approaches that seem to be working to improve some of those structural factors. So when I think about what's happened over the course of the years, as recently as September 2023, we can see that there have been tremendous impacts of this program. I mean, this is part of what makes working in this space so intoxicating. I mean, 25 million people lives were saved as a result of PEPFAR supported prevention and treatment. 21 million people are on ART out of the roughly 40 million people living with HIV. 71 million people tested. 2.5 million adolescent girls and young women have been reached, and we'll talk a little bit more about this in a minute, through the DREAMS program, which is a comprehensive HIV prevention program that seeks to empower as well as provide prevention skills and services. OVCs, babies born without HIV, 13.4 million people who are living with HIV on ART, but also receiving TB treatment. 33 million VMCs performed since 2007. Again, one of the main tools that we've developed in recent years that has astounding efficacy, but isn't being used at the rates, isn't being taken up at the rates that it might be. And then finally, you all know that, at this point, roughly 2 million people have been started on PrEP, and just a slew of healthcare workers have been supported over the years by PEPFAR's funding, some 330,000 or more, depending on the estimates. I think one of the most interesting outputs or outcomes that have come in the last few years has been the last point here. That is, in 2022, we even saw 9 new population HIV impact assessments, ones now in their second and third generation, so much more complex. Those were conducted as recently, or completed as recently in 2022, in the midst of the COVID pandemic. I think this is a remarkable achievement for many of the countries involved. But going beyond outputs and outcomes, PEPFAR, because of its scale, is able to have impacts that you just don't see anywhere. Thinking about the DREAMS program, for example, we've seen a 25% decline in new HIV diagnoses among adolescent girls and young women in 96 of the areas where these services were implemented. 2/3 of those areas reported reductions of 40%, right? So it's clear that rolling these behaviorally and social science informed interventions can make differences on the grand scale. HIV infections have been reduced by 50% from 1.8 million annually as of 2021. And importantly, 12 countries, I'll show you slides or data for this in just a moment, 12 countries have at least surpassed the 95 targets. There's a real question about how they can sustain those gains, but this is thrilling. Right? Just think back to where we were 5 years ago, 10 years ago. These are tremendous advances. And the fact that we now are seeing that AIDS-related deaths have decreased from 2 million to 650,000 in 2021. Again, remarkable gains. I just want to share a couple of slides that really bring these lessons home. As I mentioned, 12 countries now have at least achieved their 95s. Here are 6 of them: Botswana, Zimbabwe, Lesotho, Kenya, Ethiopia, and Eswatini. And you can see, hopefully you can see my mouse as I'm following these epidemic curves. Thanks, Rochelle. I mean, this is remarkable progress where we go from new infections in these countries to drastic declines in new infections, as well as comparable or corresponding declines in deaths due to HIV in the population. I mean, across the board, this is a result of the comprehensive approach that PEPFAR has taken to respond to the pandemic. Notice we're not at zero, we're leveling off, and I think that's part of the opportunity that the new strategy envisions for making the use of available science to improve outcomes. Again, really encouraging. Here are 5 of the other 12 countries that have really made progress in terms of achieving their 95, 95, 95s. And again, you can just see that the trends are all in the right direction. We're in some cases really exceeding those 95 targets by some measure. But at the same time, we also know that if you dig a little deeper, here's an analysis of age by sex outcomes using the population HIV impact assessments. This was one from Malawi in 2020-21. You can see very clearly that, sure, we're doing quite well with some sets of the population, persons 50 years or older, men and women, in 2021, at least according to those data. But even there, you can see that with young people, males in particular, but not just them, we really are falling short of our goals of identifying 95% of those living with HIV infection, getting them on treatment, looks good here, and then getting those folks virally suppressed. You can see the same with Eswatini. Again, some segments of the population doing quite well according to these data, but many not. And you can also see really impressive improvements over the years. So my point here is to say, yes, overall, we're making good progress, even in those 12 countries and included in some of the other countries that we're working in. But if you dig a little deeper, you find that there are still important persistent gaps that need to be addressed. In 2022, UNAIDS released the Endanger Report. I don't know how many of you have taken a look at it. It's really quite informative, but it helps to identify some of the challenges that we're experiencing in the global response. So for example, we're still seeing 4,000 new infections daily. We're expected to get to have 1.2 million new infections by 2025. We've seen drastic slowing in the rollout of HIV treatment since 2009, and some of that corresponds to massive budget financial deficits. By 2025, UNAIDS suggests that we may be short $8 billion globally to respond to the pandemic. There remain persistent disparities between urban and rural divides in terms of treatment access. You can see this in every country's data that practically every country's data that are presented. And as I mentioned, responding in a way that addresses the unmet need for children is well, it's critical that we do so. There are 800,000 people young children estimated to be living with HIV. Even though they're a smaller fraction of the population, people living with HIV, they account for a disproportionate 15% of those who die from AIDS-related deaths. So again, huge opportunities to really focus on where the epidemic or where the impact is worse. And there are the persistent challenges that we have always known. Young women are 3 times more likely to be at risk for HIV infection in Southern Africa. And there are persistent HIV risks for key and priority populations, and in particular, men who have sex with men, female sex workers, and people who inject drugs. The strategy is in some ways it's structured in the same sorts of ways we've seen past strategies, right? So it really is trying to focus on some of the structural barriers that we know are hamstringing our response to the pandemic. This one sort of divides its focus into 5 pillars and 3 enabling factors. The first is really focusing on closing those health equity gaps that we know about and that persists. The second is really focusing on sustaining the response, and I'll talk about each of these in depth in just a second. Sustaining the response in a way that really meets local needs and priorities, and that allows host countries, host governments to really lead the charge, both in the response today, but in the response down the road. This strategy also really emphasizes the need to strengthen public health systems and health security with a greater eye toward not just the future COVID pandemics, or the equivalent, but also climate change and other emerging threats, well, present threats to human health and well-being. Transformative partnerships is also a key pillar for the strategy, where the goal is really to find new partnerships, ones we haven't made the most of up to date. And then the 5th pillar emphasizes the need to follow the science. And this is where the focus on behavioral and social sciences really shows up, and I'll show you a little bit more about that in just a second. I have always thought that this emphasis on behavioral and social sciences should really be one of these enabling factors that really spans the entirety of the work that PEPFAR is trying to accomplish. Be that as it may, the strategy still highlights the importance of really engaging community leadership, youth, host government, et cetera, really emphasizing innovative new approaches to close the gaps that persist with the data, within the data. And then finally, there's a real emphasis on being sure that everything that we do is really informed by the best surveillance data, as well as, I would argue, efficacy and effectiveness data. Why don't we jump in a little more deeply into what those pillars mean for mainstreaming behavioral and social sciences. With the first, really the priority, as I've mentioned, is on closing gaps for equity with key and priority populations, and taking a human rights focus to that work, supporting gender equitable programs, empowering youth to not just be at the table to inform priorities, but to really help generate new approaches to respond to the pandemic. And of course, you've heard me talk about the need to really address vertical transmission and AIDS in children. The thing that's fascinating for me is that in addition to all the work that we all know, right, around adherence and HIV testing and treatment and re-engagement and treatment, all those, I think, harder core behavioral and social science interventions that we all know, there is a slew of other research that's relevant to how we can do this in the PEPFAR universe. So for example, we know we have no shortage of interventions that really help us think about how to reduce intimate partner violence, improve economic well-being, promote gender equitable norms, right? There's a ton of evidence around using community mobilization, peer-led approaches to improve health system utilization, even in low and middle income countries. Some of these studies are coming specifically from the countries supported by PEPFAR. We know that family-centered care can boost ART adherence in mothers and children in ways that improve the outcomes in exactly the ways that we were missing. And then finally, we also see, I think it's real improvements on the horizon around challenging the anti-LGBTQ laws, intervening in ways that reduce stigma and discrimination for everybody who is engaged in healthcare, who receives services from PEPFAR supported healthcare settings. Oops. Again, you can see the same thread of behavioral science that could really inform the response through Pillar 2, right? If the focus here is on sustaining the response, part of that is developing sustainability roadmaps with countries, integrating HIV prevention into the broader healthcare system, building capacity within those systems of various sorts, I might add, and then really working to stabilize and support local and regional community-based organizations. The science there is strong as well. These are just some examples, largely pulled from low and middle income country settings, but we know that there are important evidence-based ways that we can engage key stakeholders, including decision makers. I'll talk about this in just a second. That we can galvanize political support and supportive essential services, even when doing so runs counter to some of the values held by those decision makers, right? There's, I think, exciting applications in that sense of these sciences. It's even possible to assess the strengths and weaknesses of extant health systems by taking a structural approach, like what's there, what isn't, what supports what, et cetera. And we can evaluate, of course, ways to better integrate this programming into broader health systems. And there are lots of examples recently of how to do that. Pillar 3 really focuses on strengthening the national public health institutions, continuing the support for healthcare workers of various sorts, and improving things like data systems within healthcare systems. There are priorities around catalyzing manufacturing, improving supply chains, all of that. But more relevant here is the trend that we've seen here in the States and beyond about improving patient-centered treatment and care. I know Alvin Gang has done a lot of work in this space, as has others who are still at UCSF. I think that science is now coming to the fore in a way that is positioning it well, I think, to inform how we improve prevention and treatment services in the countries supported by PEPFAR. And then finally, as I've mentioned, part of Pillar 3 is really trying to think about how we can better prepare for future pandemics and enhance the response capabilities. I think, again, the COVID pandemic was instructive. It had certainly an impact on our ability to provide services to persons living in low and middle income countries, but it was also remarkable that infrastructure enabled countries to respond much more rapidly and effectively I often wonder how those responses might have been had we not invested in some of the capacity that exists there. Again, even for strengthening public health systems, lots of science that tells us how to deploy tools, train healthcare workers and others, how to prepare HCWs, healthcare workers to use evidence-based practices to really understand who's coming into their clinics, how to refer them effectively, and how to prepare people to manage adverse side effects and challenges to treatment continuity. And then, of course, one of the lessons from the COVID pandemic that I think is relevant here, that behavioral and social sciences had an important role and will have an important role to play in really pre-inoculating people in the future against misinformation and disinformation using media interventions, by mobilizing communities, et cetera. Again, a lot of that work informed by years, decades in some cases, of behavioral and social sciences that can be used in this context. I'll begin to wrap up the overview of these, the pillar, and then the pillars, and then really think a little bit more about some of the challenges and opportunities. But pillar 4 is a little farther afield, in terms of focusing on developing new partnerships that are global, regional, national, and with U.S. Partners as well. That also engage the private sector. This is a common approach in PEPFAR, to engage the J&Js and the Gileads and others. This is certainly part of the pillar, but pillar 4. But in addition, there's a greater emphasis on developing new collaborations with stakeholders that have interests well beyond HIV, and to capitalize on marketing expertise or other approaches that can help us expand the reach of services that we know work. Pillar 4 also prioritizes finding or engaging with innovative philanthropy to support the things that often host countries and sometimes even the US government might be hesitant to support. And then finally, there is an emphasis in developing new partnerships between US and host country institutions, ones that haven't existed to date. In each of these cases, there is science that can help to improve how we approach this. Some of it from the social psychology literature, for example. Using reciprocity is one good example. Reciprocity, as you know, is a social psychology principle that really has to do with, in a favorable way, a tit for tat, doing one thing in a way that builds trust in collaborative ventures in ways that helps to encourage similar gestures and movements by your counterparties. Likewise, social proof can be used to highlight examples where countries or country teams are really making important changes around testing or policy changes, and using those differences to inspire other countries, other teams to adopt similar evidence-based approaches. Using commitment and consistency principles going back to Cialdini and others in the social psychology literature has been shown to have an effect as well in terms of negotiations to build partnerships that are lasting and responsive to the needs. And then finally, I think there are also important developments that really teach us what the key components are to help us to develop new collaborations that allow us to advance progress on our shared global health goals. I'll wrap up with this sort of in-depth look at the pillars by really focusing on where the behavioral science piece comes in. Pillar 5 is particularly that spot where the ambassador and the team is largely saying, look, let's find ways to integrate behavioral and social sciences into HIV programming. And they're very clear that they're talking about evidence-based science. Now, this is an important caveat. Having worked in this space off and on for a couple of years, but most recently over the course of the past year, I've been really kind of shocked at, and we can say more about this, shocked at the level of evidence that supports many of the programs that are offered broadly throughout the PEPFAR universe. The great thing about the latest iteration of the strategy is it says, look, we really want evidence-based science, and to use that to leverage measurable changes as a result of our investments. This is an important shift from what we've seen in past COPs. There is, of course, an emphasis on leveraging implementation science to improve known barriers, to develop next generation surveillance methods. But again, a lot of the focus, at least with respect to behavioral science, is to improve outcomes at the steps of the continuum that we all know and to do so with a particular focus on our key and priority populations. Again, there's always been, in the Berks years, there was certainly an emphasis on addressing these needs, but not with as much focus on the available science as we see in the new strategy. Again, just some examples of how we can leverage the behavioral and social sciences based in part in what's happening in low and middle income countries themselves. So we've seen some great research recently on optimizing decision making among policymakers. We've seen incredible advances with respect to mobilizing civil society to secure global funding. This was one of the major advances, if you ask me, that occurred in Brazil some time ago, that made ART widely available to the population. This was driven in part by advocating with civil society in a way that made budgets available specifically to make that possible. And then finally, there's plenty of science to help us persuade stakeholders to support targeted HIV prevention services, particularly that help us not just respond to HIV, but also prepare for future public health emergencies. And there is no shortage of ways that we've demonstrated that we can identify the implementation barriers, evaluate strategies to improve them, and monitor outcomes in ways that help to result in measurable gains for key populations. So being mindful of time, I want to begin to summarize. I want to begin summarizing by thinking a little bit about some of the challenges that currently exist in the PEPFAR interagency space, particularly with respect to applying these behavioral and social science lenses to the work that's done there. As I mentioned earlier, one of the things I've noted repeatedly is that there really is a lack of relevant scientific expertise within the PEPFAR interagency space. And I mean not just at headquarters, I also mean at the operating units in country, among donors, among implementing partners. Now, this will cause some consternation, I imagine. But again, I think this is absolutely fair to say that we really need more people who are familiar with, expert in, and really conversant in both the science, but also the application of that science to improve programming. There remains a very strong bias toward, a somewhat simplified approach where we're relying heavily on biomedical interventions and using behavioral and social science for that ends, right? Pills in mouths. How do we put more pills in mouths? Well, that is important. But I think there is an equally important need to use the science that helps us to address the social factors that we know are driving stigma, that are driving discrimination in ways that improve services. There is clearly a challenge with budget constraints. And again, I'm not even talking about the reauthorization issues, but the fact that that with every year, the goals, the targets get harder to accomplish and that require greater investments in personnel and resource, and the budgets don't improve, they don't change accordingly. This is having a drastic impact on what country teams are able to do above and beyond what they've proposed in recent years. And then finally, there is still, I think, a challenge of thinking of ways to quantify the impact of behavioral and social sciences, or at least as they can be used to inform or improve existing services, right? This is something that I'm working on to advise some of the behavioral sciences team there to really think about existing indicators that are currently used and how those might be used to really measure the investment and the outcomes resulting from more behavioral science informed approaches. And then finally, there is the challenge of really helping people understand what behavioral and social sciences are and how they can be useful here. I think there's a lot of misinformation that continues to pervade the space, and really finding ways to counter that, as well as thinking about ways to really scale and ensure the sustainability of these behavioral science augmented approaches will be an ongoing challenge. Even so, I think there are important opportunities that we can pursue to be sure that the latest PEPFAR strategy really does achieve its goal of mainstreaming social behavioral sciences. One very simple solution is to engage the PEPFAR Scientific Advisory Board. I don't know if any of you are familiar, but I think there's a board of 25, 30 people from around the world, many physicians, but not just them. Plenty of people who are certainly allies in terms of understanding the role of human behavior in, HIV prevention, treatment, care services. Really engaging those folks in a way that helps not just the PEPFAR headquarters to understand the opportunities here, but also country teams that are looking for ways to improve their services. So this is, I believe, still a really vast, untapped opportunity. We need to invest in accessible tools for knowledge sharing, capacity building, and collaboration. Right now, nothing like that really exists on the inside at PEPFAR. So if country teams say, hey, we've got this, we've diagnosed this behavioral problem, let's say, in getting men in for testing, where do we go for a compendium of evidence-based interventions or other approaches that can really help us? It doesn't exist. That's not hard to build, in my view. I think there are incredible opportunities to tap into showcase host country capacity and to use that to use that to help close gaps, expertise gaps throughout the PEPFAR countries. Recently, some of you may have joined a symposium that PEPFAR offered. This was the first behavioral science symposium. I think it was November 2nd or so, and we invited a range of people whose work Ruan Barnabas and Sandy McCoy, and a number of other presenters from Uganda and South Africa, I think it was. This was a great opportunity to highlight some of the ways in which behavioral science is being used to improve services on the ground. We need to be doing more of this, and I think we need to think strategically of how to identify that, the successes in country and the experts who are familiar with their implementation. Clearly, we need to improve data collection. I've mentioned, the real challenge of measuring our impacts. This is something that, frankly, I will continue to advocate that we assemble a working group, or I will advise that we assemble a working group at PEPFAR to really think about how to identify specific indicators and measures for doing so. And we clearly need more resource. I mean, there was a time when there was headquarters operational planning funds, HOP funds as they were called, that really supported a lot of implementation science and other research to help address unmet needs. That doesn't exist at present. And part of that is because of the funding environment that I mentioned. But there is still the capacity to develop new funding mechanisms in partnership with J&J, with Gates and others. And these are, I think, important opportunities for us to consider. Finally, I'll say this issue of fostering host country ownership is essential if we're to really achieve a sustainable response that incorporates behavioral and social sciences. And the way to do that, or the successes that at least I have seen that demonstrate that that's possible, is to really be sure that that PEPFAR takes more of a back seat. This is, Wayne was asking me when I was preparing this presentation, think about how the current PEPFAR strategy differs from the past. And anybody who's been in this space will have a lot of ideas about the difference between a PEPFAR run by Ambassador Birx, who I respect immensely and owe a debt of gratitude to that I'll never pay off. But it is clear that there's a different emphasis at PEPFAR these days on really ensuring that what is fielded is responsive to local needs and priorities. And that is developed with an eye toward ensuring that host countries are able to sustain these affordably in future years. I'll wrap up here by saying simply that the new strategy, in my view, is a cause for celebration. It certainly embraces a more comprehensive approach that integrates behavioral and social sciences, but not just those. It really emphasizes the need to incorporate evidence-based approaches for the specific challenges we all know along the treatment continuum, but also the prevention cascade, if I may. I think it also recognizes in a genuine way that human behavior is integral to our ability to provide effective services to people living in low and middle income countries. And the new strategy also, we didn't talk much about this, really underscores the need for addressing mental health, substance use, social support, community engagement. Again, these social indicators, these social factors that we know have a bearing on human behavior. And finally, it really does signal a clear shift toward co-creating and scaling evidence-based approaches that meet local needs and priorities. Why don't I stop there? Rochelle, at the end of the deck, I have citations for a lot of the studies that I've included. I'll wrap up though by saying simply, again, I think with the new strategy, the new leadership, we have an unprecedented opportunity to be sure that behavioral social sciences are integrated in a way that helps us to improve HIV prevention and treatment services in ways we haven't seen before. And so I would really, and hopefully we'll talk about this in the question and answer, I really encourage this team in particular, but not just them, not just you, to think about how to bring the science that you have helped to develop and demonstrate the efficacy for, in a way to bring that science to a space that really is constrained by resource, capacity, etc. Right? So whenever we think about new initiatives, often there's a conversation that's in the works between PEPFAR and NIH, and I guarantee you that a lot of that focus will initially be, well, what new randomized controlled trials can we do? And we can talk about this more in the question and answer as needed, but I would say, no, I think the challenge here is to find ways to use the existing evidence, the things that we have efficacy for, and to really focus on scaling these things up. What are the challenges? How do we do so in a systematic way? What implementation models do we use to do so? And then we take that approach to really accelerating the response that uses the science that you and I know very well. So with that, let me just say thank you for your time, and I'd love to entertain any questions or hear any comments that you'd have to share.
Fantastic. Thank you, Andrew. That was a spectacular overview, and I'm sure it has generated a lot of questions and discussion points. There's been a few comments in the chat, a couple from Judy Auerbach and then one from Edwin. If either of you would like to come online and share your comments live, that would be great. Or if you want to let them ride in the comments, that's fine too. And open it up to anybody else who has comments or questions.
So that Andrew, thank you so much for an excellent overview, tour de force of what presumably is happening at PEPFAR in this new strategy. And as you can tell from my comments in the chat, Andrew and I are working very hard to try to get them to be, the apparatus to be much more attentive to what we understand behavioral science to mean, as opposed to what they think it means. And so it's just an ongoing struggle. You've heard me talk about CROI and other venues where there's just this real difficulty in breaking through with people primarily trained as MDs, but also even epidemiologists and others who think they know what we do, but don't really know what we do. And pretty much, I think the answer in part and partly to Edwin's question as well, and I want Andrew to actually answer this, is getting them to be more specific about what they actually need and want, and to acknowledge that it's not the range of what we do in behavioral and social research. It's really a very limited set of things that are mostly behavioral and really behavioral, to a lesser extent, social research in service to their clinical and medical outcomes that they're aiming for. So I'll shut up, but I just very much appreciate all that you're trying to do, Andrew, in this context.
Thank you, Judy. I wasn't sure if Andrew wanted to respond or whether you're...
Since Edwin's, it may be related, we take both of them, and I'll do my best to respond.
Great. Let me just queue up the others. So Edwin, and then Ariane was after Edwin, and then Holly was after Ariane. So take it away.
Yeah, no, I was just interested. I know, we can hear the work that's been going on, but what really is the best way to assist the leadership up to speed on social and behavioral sciences? I think earlier that they don't know what they don't know, but what has proven with the new leadership, what has proven effective in getting the points. The points across, like what are they open and receptive to, and what are the potential mechanisms? I jokingly said, the Clockwork Orange approach, where we just force everything in. But knowing what you know of the new leadership and how they've been able to incorporate new information or missing information, what are the ways that we can try to aid in that process?
Yeah, Edwin, that's such a great question. And Judy, your point is well taken as well. Let me see if I can respond to those. Going back to Judy's, I think that the opportunity here, the trick here is going to be to give the headquarters team exactly what it needs, and part of that requires us. I hate to say it, but I think it's true. Part of it requires us to take a step back and to realize that this will never be the ideal space for the work that we do. It will never be the ideal space. That is, at best, we're going to be able to get little bits and pieces into the programming, into the overall strategic direction that helps to shift how programs are implemented. I think we need to be very specific. Maybe it's a matter of doing what CDC previously did, really identifying those evidence-based, actually assembling a compendium of evidence-based interventions that really are ready for scale, that address very specific questions along the care continuum in the prevention cascade. What do we know about testing for men? What do we know about addressing services or changing services for adolescent girls and young women, or young people broadly? I think we need to be very specific about the tools that exist, and to be willing to provide additional support, because country teams will see the papers and the publications that are in the literature and they'll say, great, but how do we do anything with this? If you go back to the compendium that CDC has developed, and you ask any of the researchers whose presentations appear there, what have you done to be able to make that available? Where are the user guides? Where are the manuals? These things. This is ultimately what country teams need. They need the specifics about how to implement. So I think that speaks to part of what the PEPFAR headquarters and operational teams will need. How do you go from these efficacy trials to implementing in resource-limited, personnel-limited settings? I think how to do that. I think the SAB meets every quarter, every 4 months. I can't recall. Judy, you would know better than I. And I think showing up to those, and often there are public comment periods. I think being able to share with that board the insights that you and others have would be essential. I think at the same time, really engaging the SAB and urging PEPFAR to do so, to use its behavioral and social sciences experts to really weigh in on these implementation challenges. So I think those are the pressure points that the field should really try to prioritize if we're going to have a chance of changing how the science is used as part of the program.
Great. I wanted to point out, so Holly, your question seems related to this. Do you want to jump in here in front of Ariane just in case it's thematically related?
Thanks.
Sure, if Ariane doesn't mind. I thank you for your presentation, Andrew. I was just curious, I'm a TAPS fellow, and I was just curious if you're aware of any opportunities for postdocs to get involved in this advocacy. I see it as a really important period and also important for my career.
That is such a great question. I mean, I don't know, but will you let me think about it and maybe respond through Rochelle? That's the best answer I can offer right now. I don't know of any off the cuff, but let me think about it.
Great. And I know Andrew, he will follow up, so stay tuned. Okay, Ariane and then Susan.
So thank you, Andrew, for this beautiful tour de force and presentation of PEPFAR. I think it's very insightful. A comment about the fact that it's not just PEPFAR, and many of you know about that in this group, but it's not just PEPFAR who is resistant to social behavioral science. I have had experience with some of the NIH funded networks, including right now with the HPTN. There's a huge amount of resistance to think about integrating social behavioral and structural issues into our research program with the network, and some of the networks like the treatment network are even more resistant. Because, and in a way, I mean, it's a remark, but, I think it would be nice that we stop talking about biomedical product or intervention and we talk about biobehavioral, because that's what Jane Simoni proposed several years ago. And then we sort of stay away from that dichotomy, because there is no dichotomy. There is nothing that is not behavioral and we therefore are social, and we always have to integrate it. So that's kind of one point. And maybe if we all change our vocabulary, it's going to change how scientists and researchers and implementers think about these strategies. It's not one or the other, it's everything, and it's a package. And then I did want to say a couple of things that, at least within PEPFAR USAID, they are really making an effort through several of their programs, like Matrix, which is very early on product development at preclinical and early clinical stage, and then sort of scale up and of approved prevention strategy through Mosaic to really bring in the social behavioral and science side. I think what we're lacking there are tools and standardized way of measuring, impact and all that. So I really like your idea of creating compendiums of intervention, but also instruments, measures, approach that can be cheaper, but still effective, because we have to do more with less. And that's the reality of our world. So I'll stop there. And if you have any comments, I would appreciate it.
I do. First, thank you. It's good to see you, by the way. And you, of all people, I mean, I can think of other folks who really know of the challenge of advancing biobehavioral research in the networks. You and I worked pretty closely with the Microbicide Trials Network years ago, and just the fight to get any behavioral social science on the agenda was a real fight. Two things seem to change to make that happen, and maybe this is instructive and relevant to the comments that others have raised, Edwin and others so far. One is, Ben Moss, you might remember, did the best paper in the middle of 035, MTN 035, I think it was, might be forgetting the names, where he basically said, hey, look, if you don't get adherence right, here's how much you're going to dilute the effect of a topical microbicide. You're going to lose power. You're not going to find the effects that you're looking for if you don't address adherence. This was a hard endpoint, a point estimate that really made, I think, leadership and NIH, I was on the NIH team at the time, think, good Lord, we really need to get this under control. And then secondly, the results were clear as day, that one of the main reasons that the microbicide trials product didn't work was because people simply weren't using it. They were saying as much, but if we had used a more systematic approach, we could have uncovered those challenges earlier and addressed them. So Ariane, I think those kinds of lessons are absolutely relevant here. The lessons that we've gained over the years trying to bring this science or create a more integrated approach to this science, I think those lessons apply here. So anyway, I just wanted to acknowledge your experience, and thanks for seconding the idea of developing a compendium, measures, indicators that can really help us track our progress.
Great, thank you. Susan.
Hi, Andrew, nice to see you.
You too.
A few years ago, pre-COVID, I was doing research with Tim Lane in South Africa, and we came up with some good results on testing. And then PEPFAR took the, and I don't know how the whole mechanism worked, but PEPFAR took part of the intervention and then started implementing it. And I understand it's still being implemented. But I saw the goals, how many tests they were trying to get, and they were just absurd. I mean, there was just no way to reach those kinds of numbers that they were trying to get. And so it felt like the deck was stacked against being able to show that the program had worked, because the goals were so unrealistic. And it didn't take into account that, it's not like you have a set of arms all out and all you have to do is, go down the line, that you have to get behavior change for people to, it takes a while. Yeah. So I'm just wondering what your thoughts are about that, and has that changed?
So I think what you're describing is a fair way to describe the difference between PEPFAR under Birx and PEPFAR under Nkengasong. In the Birx era, the targets were handed down from on high. And again, I was on those teams, and I struggled with my role in working with Tanzania and Nigeria in particular around that. Those targets were often unrealistic in the ways that you described. And they didn't acknowledge that country teams themselves said, well, look, we don't have the capacity. We don't know how we're going to be able to do this. the current era, and I know this raises real concerns for some long-standing PEPFAR folks, the current era of PEPFAR really is much more collaborative in that sense. It says, tell us, use your data, the country data, help inform what these targets should be, and let's set them together, right? So it's not handed down simply from PEPFAR, or they're not handed down simply from PEPFAR. I think that's an important change. I don't know to what extent the intervention that you and Tim helped to develop is still being used. It's hard actually to dig down into the country operational plans or strategic direction summaries. These are the documents that say, here's what we're going to do to address these issues. I hope it still is. But again, maybe that's part of the opportunity moving forward is, working with the scientific advisory board at PEPFAR to say, hey, PEPFAR, show us what are the specific interventions that are being used right now, and how can we be sure that the best ones for the specific challenges that your country teams are encountering are being used. So that's what I would recommend going forward. Is that, and again, Susan, I think having you speak up in the various ways that you might through an SAB meeting or through contacts with PEPFAR, these are ways to sort of trigger that team to think about how to measure what's being done and frankly how to be accountable.
Thanks.
Great. All right. Thank you, Susan, for that question and for that response. Andrew, we are right at the end of our hour. And so I want to again thank Andrew for this great presentation and the great discussion, and offer on his behalf, even though he hasn't authorized me to do so, that he would welcome follow-up from you. And perhaps, Andrew, do you mind putting your email address in the chat that people can reach you at if it's
not?
I don't think I saw it in your slides. And if you don't see that, you can follow up with Rochelle or me, and we can put you in touch. But for now, thank you, Andrew. This was outstanding and much appreciated.
Thank you so much. Nice to see everybody.